Okay, good afternoon, everybody. I'm going to make some announcements, and then we're going to have the good doctor come and speak with us. My name is Tony Variant, and I am a hearing loss research specialist and also the president of the chapter. Okay. I had some very clever slides here. I like this one. Whoops. If you heard, let's go back. Right. If you heard, the ants are my friends, they're blowing in the wind, you probably need a hearing test. Okay, I thought that was very, very good. So let me move forward on some of these slides. It's not working.
Needs a microphone.
Testing 1, 2, 3, maybe.
Adjust the volume.
It should be already adjusted. Oh, there you go. We're having the microphone adjusted. This meeting is being recorded and we will put it on our YouTube channel. Important for everybody to know, HLAA does not endorse any single product or service, and this meeting is intended to provide information, education, and support. And I'm going backwards. Caption Call is our sponsor and has been since 2015, and they actually pay for the captionist. Our captioner is Jo Gale, and she is captioning for us, and it shows up on the screen here. If you would like to see the captions on your smartphone, there's a QR code you can scan on your smartphone, and they will come up.
Let's try this one, see if this one's better.
Okay, I think she's in the back there fixing it.
Yeah, but she says she has it all the way up.
Oh. Okay, is this better? Okay, good, good. So Caption Call provides captioning for landline phones, and that could be the old-fashioned AT&T type phone, or it could be the new Verizon type, it could be Vonage, it could be any kind of physical phone, and they also provide captions on a smartphone. It just requires the download of an app, and you have to self-identify as a person with a hearing loss. There's no charge for these services. The landline phones, they could come out and set it up for you in your house. With a Caption Call trainer would do that. And the iPhone or the Android, you can download from the store or from the Google Play Store. And it certainly makes understanding phone calls a lot easier. And one of the big benefits is that you can save the captions for review after. So if you're getting a telephone number or an address, you can always verify that you heard it correctly and look back on your captions. Okay, and there's a picture of our captioner, Jo Gale. And even though she has the Golden Gate Bridge in San Francisco, that's not where she's at. She's in Chicago, Illinois. Okay, all right. We are a 501c3 nonprofit. We are one of many chapters in the United States. Our main office is located near Washington, D.C., and This is where they do most of the advocating through the Federal Communications Commission for our captions on TV, captions everywhere, for communication access in every way. I do want to announce, I put it on a flyer. Everybody should have we have 2 events coming up. One is our walkathon, Walk for Hearing. It's coming up on Saturday, May the 31st. And we invite people to sign up and walk as a team. And it's in Long Beach. So I realize that from here, that may seem far away, but we could carpool. You can come with me and be more than happy to have you come with me. I got a minivan. I can seat 9 people. 7 people. Happy to fill you up and we'll have a fun time. It's like a 3-mile walk, and some people come and just be a cheerleader because they don't want to walk the walk. Also, the whole purpose for the walk is to get fundraising. 40% of all the funds that are raised for our team, Orange County Walkers, comes back to the chapter, and the rest goes for next year to fund the walk next year. So this is May 31st. I'm going to talk about it some more. I put a link on the back of your agenda so you can find the walk online. Also, this is so exciting. Every year, the Hearing Loss Association has an annual convention. Last year, in June, it was in Arizona. That was close. So I drove there. That was wonderful. This year, it's going to be in Indiana, Annapolis. Indiana. Yeah. There is a complete agenda of programs. There's a general session. The research symposium is going to be on stigma and hearing loss. And there's a welcome party. I'm not sure who's putting that on this year. I know Caption Call in the past has been very generous with those. There's an exhibit hall that is huge, and everything you can imagine that somebody with a hearing loss could use would be there, demonstrate. You could speak to the representatives. It's sort of like Christmas. So there are special rates up till March the 14th, which is just 4 days away. But there is for the officers of the chapter, there's a special discount, and also there's a delegate rate, delegate. So if you want to go, I can give you a $150 discount on the convention registration. But I should know about that this week if you're interested. Please, I've also put the link on the back of the agenda. So when you go home, you can look and you can see the schedule of all of the workshops that are going to be presented. And so they talk about cochlear implants, they talk about hearing aids, they talk about accessibility and meetings, they talk about the different types of technology available. Like in this room, there's a hearing loop. So they'll be talking about using Bluetooth for communication access. There's also something else coming out soon called Auracast. So there will be speakers about that, the different types of technology and how to connect to them. So, hi there. All right. Before we get too far going here, I want to acknowledge some people in the room. In addition to Dr. Mahboubi, is also Ken Post, hearing aid dispenser. So if you want to talk to a hearing aid dispenser, Dr. Gabby Rodriguez from Amazing Hearing is here. And in the back, we have Lane from Caption Call, and I can't hear you from here. Yes. Anyway, you can talk to them after the doctor speaks. They're here to answer any of your questions. If you have problems hearing accurately on the phone, they can provide captions for your home phone and for your mobile phone. And so please come and talk to them. Yes. Okay. So acknowledging people in the room. And again, the convention is coming up in June. June 11 to 14. It's a kind of a long weekend, and they are fantastic. Every single meeting is captioned. Every single room has a hearing loop. Everything is done to make sure that you hear every word. And if you go to HLAA online and look at the agenda, you can see all the workshops. They're phenomenal. Okay, now I'm instituting something called office hours. So I've had a lot of people try to talk to me during meeting time, and it becomes very confusing. People coming and going, and it gets loud, and it gets confusing. So office hours is a time where you can come and sit with me quietly. I rent a little meeting space, and the next time is going to be March the 18th between 2 and 4. And if you'll RSVP, make an appointment with me, and I can help you with resources that you might be available to you to use. First of all, in Laguna Woods Village, every single clubhouse has a hearing loop. If you don't know what a hearing loop is, and can't wait for one of my meetings when I explain it all, I'd be more than happy to explain it and demonstrate it for you and what you need in order to access hearing through the hearing loop. So there's places like board meetings in the community center, the PC workshop, the PC Learning Center has a loop. So there's no excuses that you can't take classes because you can't hear. If you use the hearing loop, you should be able to hear very well. If you need to have t-coil equipped hearing aids. If you don't have t-coil equipped hearing aids, you can borrow a receiver. All the locations have a receiver. So this is a receiver, and you wear it around your neck, and then you wear a headset. If you don't have hearing aids and prefer to use earbuds, bring your own earbuds, and it will plug into the receiver, and you'll hear crystal clear, no background noise. I think it's time that we, oh, Alan, where are you? Okay. I want to pass the basket. One of the ways that we survive financially, pay the rent here, is that we take donations, and there's no charge to be here. Don't feel obligated, but if you can put $1 or so, Alan will pass the basket, and we appreciate it. Okay. You want to come on up? I'm going to introduce you to Marla Peoples. She's the vice president of the chapter, and she's going to introduce the doctor to you. Let's just see. Wait a minute here. I didn't do something right. What happened? Here we go. Uh, okay, but now we need to get back. Okay. We got it. We got it.
Thank you, Tony.
Marla Peoples, thank you.
If you haven't known by now or guessed by now, Tony Berrient is a tireless advocate for hearing loss. She does so much for people with hearing loss, and she does so much for this chapter as president. And if any of you have an interest of joining our team and helping out, we greatly appreciate it. I know, having been a president or a chairperson of the City of Orange chapter for 5 years, how much work there is into leading a chapter. So again, if any of you are interested in joining us on our steering committee, we'd be very happy to have you on it. I'm going to introduce our speaker, Dr. Mahboubi. He is an otologist and neurotologist and a skull-based surgeon. He completed his residency at UC Irvine, followed by a clinical fellowship in otology and neurotology at House Clinic in UCLA. Dr. Mahboubi has published extensively in national and international otolaryngology journals and authored several book chapters in neurotology and neurosurgery textbooks. He's a member of the American Neurotology Society. And one of the reasons why I wanted to do this introduction is because he's going to be speaking about sudden hearing loss. And I have had sudden hearing loss. And you'll be able to see the differences in treatments from when I had it back in 1967 to how they treat it now. But one thing remains consistent, is that when you have sudden hearing loss, you need to act fast. You need to act quickly. When I was 13 years old, I woke up one morning and I had a fullness feeling in my right ear. Now, I was already deaf in my left ear since birth. So I wake up, I have this fullness, I have this feeling that's plugged up. And so I thought, okay, I'll just pinch my nose and force air through there and it'll pop my ears and it'll clear up. I did that several times. It didn't clear up. So then I began hearing this noise. It was like these bells and whistles and like you put a shell next to your ear and you hear the ocean roar. And I asked my mom, where's that noise coming from? And she said, what noise? I said, well, it sounds like, you know, if you put a shell to your ear, you hear the roar of the ocean, you hear bells and whistles. She goes, I don't hear any noise. So that was my first occasion with tinnitus, which has stayed with me ever since. So I was seen by a local ENT. He referred me to the House Clinic in Los Angeles. I saw Dr. Howard House first. Then he passed me on to Dr. William House. I had a multitude of tests. I had 120 allergy shots. I had some intravenous niacin. I had a lot of x-rays, just a lot of things. And finally, the diagnosis was cochlear eye drops. I had fluid buildup in the inner ear, which had destroyed the hair cells. Now, once the hair cells are destroyed, they don't regenerate. They don't go back. You lose that hearing. So Dr. House, in one of the meetings, he took out this thing that I have to say must have been the most ancient hearing aid. It was a long tube and it had a small end that you put in your ear and it had a large end that he would talk through. And he talked to me and he said, we're going to do surgery. We're going to do a shunt and we're going to relieve that pressure from that fluid in your inner ear so we can help preserve your hearing. And it's called a subarachnoid endolymphatic shunt. And now that was, he was a maverick. Not a lot of people were doing that at that time, But as far as I'm concerned, he was able to stabilize my hearing. It fluctuated for a few years, but I was able to maintain that hearing for 44 years until I woke up one morning, put my hearing aid on, and it's like, I'm not hearing well with this. Something must be wrong with my hearing aid. Called my audiologist. She tested me. She goes, you know what? You've got the strongest hearing aid. This isn't going to help you anymore. You need a cochlear implant. So at that point, then I had to look into getting a cochlear implant. But the important thing with sudden hearing loss, you have to act fast. But the treatment they do nowadays is a lot less invasive than what I had. But I do credit that it did help preserve my hearing. So without ado, I'd like Dr. Mahboubi to come up and talk to us about sudden hearing loss.
Right. Hello, everyone. Hopefully, my voice is loud enough. If not, please let me know to speak louder. Okay, already getting hints from the back of the room. My name is Dr. Mahboubi. Very nice to meet everyone. It's a pleasure to be here and talk to you guys. And I would like to thank the chapter for inviting me to be here. I'm one of the neurotologists at the Hossein Clinic. We have offices in Los Angeles and Orange. And Marla wanted me to also talk about a little bit about kind of what neurotology is. Because it can be confusing. Sometimes we have patients coming to our office thinking we are neurologists, but we're not. So neurotology or otology is a subdivision of otolaryngology or ENT or ear, nose, and throat surgery. And much like an internal medicine doctor, they train and then they can specialize in GI problems and cardiology and rheumatology. Same way ear, nose, and throat surgeons, when they finish, they can start practicing as a general ENT, or they can further pursue training and then focus in one area of ENT. So some people do what I do, which is otology and neurotology, which we focus mainly just on the diseases of the ear and the lateral skull base, which is essentially the temporal bone that is the side of the skull. So with that being said, we'd like to talk to you guys today, as Marla mentioned, about a condition called sudden hearing loss. Now, before us mentioning it, I'm curious, I want to do a quick survey. How many of you had heard about this condition or know what it is? Okay, so probably like 40% of the people present. So this is not a very common problem out in the public. Like if you ask friends and family, probably no one else has had it if you have ever seen someone with that. But in our office, we actually do see this a lot, and it tends, and as I explained a little bit later, it comes in waves. And actually over the past month, we've been seeing a spike in the number of patients who come to our office with sudden hearing loss. So I would like to start by presenting a case that I saw a few months back. She was a 39-year-old female, healthy. She came to our office. She woke up essentially very similar to the story that Marla has. She had severe ringing in her ears. She felt plugged up, and she had just returned from a cruise a few days prior to that and was feeling a little bit under the weather. This had never happened to her before. Super healthy person, young, athletic. Anyways, she was, I guess, on top of her health, and she called our office, and as soon as we heard about this, had her come in. So we examined her, and for those of you who may have never seen inside of an ear, this is what we see when we examine ears. Let's see if the laser here works. So this is the ear canal, and that's the eardrum. It is looking, the colors are much better on my screen. It's a little bit faded there, but what you see here is, is the eardrum, and this is the first hearing bone or malleus bone that attaches to the eardrum. So as you can see, there's no wax, has a kind of a pinkish color. That's a normal ear. There's no infection. And the eardrum is translucent, so we kind of see kind of shadows behind it, and there was no fluid or anything. So in essence, this would be considered a normal ear exam. So we essentially ruled out swimmer's ear. We ruled out impacted wax. Then we got a hearing test for her, and this was her hearing test. So I'm assuming most of you have seen a hearing test before, but let me try it with the mouse, see if this is better with the mouse here. Yeah. So this is what is called an audiogram. For those of you who've never seen it or nobody has ever explained to you, the horizontal axis is the different pitches that the audiologist tests. This is the part where they do the tones from low pitch to high pitch. They go up and down on the volume, and the patient kind of clicks on the button when they hear the noise. And then the y-axis or the vertical axis is the loudness level of the machine that's producing the sounds. And as you can see, unlike most other graphs, kind of the numbers are in reverse, meaning the top of the chart or the graph starts kind of at -10, 0. And then as you kind of go towards the bottom, the numbers get larger. In essence, this is much like looking at, let's say, TV volume, right? If someone can hear the news okay at volume 10, it means that they have good hearing. If they have to turn it up all the way up to 50, it means that their hearing is worse. So that's the idea behind having the audiogram kind of depicted like this, because the larger the loudness is, or the higher the loudness is, the lower the patient's hearing is. So you want the lines to be way up at the top of the audiogram. So the red line with the circles was her right ear, and we consider 25 decibels of hearing as the normal threshold. So above this 25 line is considered normal hearing, and her right side was perfect. But look at the left side. This is considered a moderate to severe sensorineural hearing loss. And the second part of her hearing test, as many of you have done that before, is the word understanding test or speech recognition test. And on the right side, she scored perfectly, 100%, but on the left side, she scored only 24%. So that's a pretty bad level of hearing loss. Now we need to kind of look at the anatomy and physiology of hearing to kind of understand the concept of sudden hearing loss. This is the anatomy of the ear and how we hear. If you have ever been to an ear doctor's office, you probably have seen the charts on the walls. The outer ear collects the sounds, directs them towards the ear canal. Then you have the eardrum at the end of the ear canal, and the sounds hit it, and they cause micro vibrations or nano vibrations that you normally don't see with naked eye. But there are little bones behind the ear that they pass the sounds to the inner ear that is deep in the skull. So when we look at an eardrum, when we examine patients in the office, we actually do not see the inner ear. The only way to look inside of it is to get a CT scan or MRI. And even then, we can't see too many details, but that's the best we got so far. And around the ear, we have the mastoid bone, which is this porous bone that extends behind the ear as well. Brain is above the ear, and then you have the great vessels, the carotid artery taking the blood to the brain that passes next to the ear. You have the jugular vein bringing blood back from the brain. And the facial nerve also passes through the ear and exits right underneath and then innervates the face. So we can have three different kinds of hearing loss. There's what is called the conductive hearing loss. That is when the inner ear is fine, it's doing its job, but there's a problem with this conductive mechanism, meaning sounds are not making their way to the inner ear. If they do, the patient would hear fine. So think of someone with a perforated eardrum, or someone with just a bad cold, they have fluid stuck in their ears, or someone who has a congenital problem with their middle ear bone. So technically the inner ear is okay. If you fix it with, let's say, hearing aids or a surgery, they can potentially have normal hearing. Then we have the second kind of hearing loss, which is called sensory neural hearing loss. This is when we examine the ear, everything's looking fine, the eardrum's good, patient has never had issues, there's no wax, no fluid, but the inner ear has just lost its ability to process sounds. So think of age-related hearing loss. Think of patients who lose hearing as a result of chemotherapy, or some kids who are born congenitally hard of hearing or deaf. And then there's a third type, which is called the mixed hearing loss, meaning patient has elements of both kinds of hearing loss. So what Marla was mentioning with the hair cells and everything, this is kind of what inside the inner ear looks like. It kind of looks like a seashell, so surprisingly, and kind of has this kind of a curvature, like a that kind of goes up like a pyramid. And then you have fluid chambers inside the inner ear, and then you have these on the right side of the screen. You have the hair cells, and they have little spikes. They're not actual hairs. They kind of look like hairs kind of coming out of these cells. And when sounds get to the inner ear, they cause kind of little vibrations of the fluid, and these little spikes, they detect it and turn it into a signal that then goes to the brain. So Sudden hearing loss, in essence, is a sudden sensory neural hearing loss. We kind of abbreviate it because it's a long name, but when we talk about sudden hearing loss, this is what we actually mean. We don't mean by somebody who woke up, couldn't hear, comes to the doctor's office, it's just a ton of wax, we clean it, they're fine, they go home. So that's not what we mean. It is in essence defined as a sudden or rapid loss of hearing that occurs in one or both ears within a 3-day period. But usually it's an overnight type of a deal, meaning usually patients wake up or they shower, they come outside the shower, all of a sudden, oh, wait a minute, what's going on? I can't hear the water getting to my ear. So usually it's much more rapid, but technically if it happens within 3 days, we still consider that a sudden hearing loss. And it is a true emergency of the ears because, as I mentioned, I will mention a little bit later, the treatment is time sensitive. And I cannot emphasize enough how often we get patients that they woke up, oh, they thought, oh, it's going to get better, or maybe they just have some wax, they put some Dubrox or peroxide in their ears. By the time we see them or by the time their primary care physician refers them to us, it's already been 2 weeks or a month or 2 months. And sometimes they come like 6 months later. And we're like, we're sorry, at this point, there's no chance of bringing your hearing back. So if this is promptly managed, there is a high likelihood of recovery, but still it's not perfect, as I will mention a little bit later. So the incidence is about 5 to 7 in a 100,000 population, or in the United States, about 66,000 new cases every year. And it is defined as a drop of 30 decibels or more of sensory neural hearing. Again, not the conductive hearing loss, but the sensory neural hearing loss. And it is defined as this happening over 3 consecutive frequencies. So if you look at the hearing test of the patient I just presented, you can see that this is way more than 30 decibels, and pretty much it is across the, all of her hearing spectrum. So what are the symptoms? So it is a sudden onset of hearing loss. So that's the most common one. Patients feel like their hearing aid may not be working if they already wear a hearing aid, or they just feel like they just can't hear, or sometimes they are kind of laying on the couch, they lay on the right side, they hear the TV fine, and they turn and lay on the left, and then, wait a minute, I can't hear the TV anymore. And they kind of realize about that. Muffled hearing or change quality of hearing is another common symptom. Feeling full, feeling pressure, these are also common. Tinnitus or tinnitus is another common presenting symptom. And as most of you probably know, it is defined as a noise that the patients hear and other people in the room don't. It has been defined in different ways, objective tinnitus, subjective, but the most common one that matters, at least from a clinical standpoint, is whether it's a persistent noise or tone, or is it a pulsatile tone? Because sometimes patients come to us thinking, oh, they just have good old tinnitus, and then we talk to them, and they say, yeah, it's more of a whoosh, and it kind of pulsates, it goes like, whoosh. That is not a regular tinnitus, that's usually a vascular problem that has to be investigated. Could be something dangerous, could be a tumor, could be an aneurysm. But here, when we say tinnitus, we essentially mean just a regular monotonic or kind of like tonal or noise-related tinnitus that would be constant. And some of these patients also have dizziness or vertigo, and they may experience it at the same time that the hearing loss happens, or sometimes could be within that vicinity, meaning maybe they had dizziness, vertigo for a day or two, and then the sudden loss happens, or vice versa. They initially had the hearing loss, but the next day they experienced the vertigo or dizziness. So when they come to us, we start by taking the history, see exactly what happened. Has this happened before? How long has it's been going on for? When did it happen? What other symptoms they have? And then kind of what's changed with respect to the previous hearing, because oftentimes patients actually have some underlying hearing loss. So is it the loudness that has changed? Is it the quality? Sometimes people say, yeah, I had some hearing loss. I would always wear my hearing aid. It was fine. But since this morning, everybody sounds like Mickey Mouse, and it just sounds funny. And then we know, okay, shoot, this patient, actually they've had not a flat hearing, sudden hearing loss, but certain frequencies have dropped more, and now they hear everybody kind of speak in a high-pitched voice. And obviously we talked to them about the previous medical history. Have they had any sort of infections, any autoimmune diseases, any tumors, cancers, chemotherapy? All of this matters, as I will mention in a bit. We essentially try to look for any other explanation, because sudden hearing loss is considered an idiopathic condition. Idiopathic in medical terms means we don't know what causes it. Because if you have, let's say, diabetes, how is it diagnosed? You get a blood test done, they look at your sugar levels. We have criteria, we've tested, thousands and, hundreds of thousands of people. We know what the normal range is. The inner ear, the cochlea, it's deep in the skull, as you guys saw in the pictures. So there's no way of accessing it without a surgery or general anesthesia. And the fluid that is within the cochlea is actually contained. So there's no blood test that will tell us what's going on inside the cochlea. As I mentioned, you can get an MRI or CT scan to look inside, but even with that, you're only looking at big picture problems. Is there a lesion, a big lesion, a tumor, or sometimes you can see maybe bleeding with certain like MRI sequences, or if there's anything going on the brain side, is there a stroke going on? But if everything's normal, and again, that's kind of the purpose when I say we try to rule out other things, meaning if on the paper everything's fine, then we call it a sudden sensory neural hearing loss. So physical exam certainly matters because we need to make sure there's nothing else going on. Hearing test that I mentioned, and labs and CT scan are usually not recommended. So if you ever experience this and you go to an ENT or an ear doctor, for the most part, they're going to recommend MRI because MRI is great at looking at brain tissue, at nerves, at soft tissues. Bony structures, if you've ever looked at an MRI or a doctor has explained it to you, bony structures, they look hazy and black. On the other hand, CT scan is great at looking at bony structures. You see all the bone lines beautifully, the mastoid air cells, the middle ear bones, but then all the soft tissues look great. So they kind of complement each other. So for a sudden hearing loss, MRI would be the best modality because if there is a tiny tumor inside the inner ear or on the hearing nerve, MRI would be able to catch it versus a CT scan will not be able to. But if, let's say, this sudden hearing loss happened after a patient fell from a ladder, then we would get a CT scan because now we're looking for a question. We're trying to answer, okay, is there a fracture that is going through the inner ear? Because then that's a different story. This is not what we mean by a sudden hearing loss. It is technically a sudden hearing loss, but not the idiopathic sudden sensory neural hearing loss that we are trying to kind of address today. So as I mentioned, majority are idiopathic. We think it's a virus because of all the treatments that people have tried. Steroids work the best. And oftentimes patients have had kind of a cold type symptoms that came back from a cruise or their kid was sick and this happens a few days later. So in these cases, we usually blame it on a virus. Back in the day when they were doing surgeries on these some of these cases early on, they would like sample the inner ear fluid and test it, and they saw some increased kind of antibodies against viruses. So these are the working theories, but in essence, when somebody walks into our office, we actually cannot prove it to you it is a virus. We check for everything else, and then again, if everything else is normal, we blame it on a virus. So if you think about, let's say, COVID infection, nose is pretty accessible, right? You walk into an urgent care, a doctor's office, they suspect COVID, they can swab it. We cannot do that for the inner ear, unfortunately. Now, if patients have vertigo at the same time, we then call it labyrinthitis, which means inflammation or infection of the entire inner ear. And if they have facial paralysis or facial palsy and rash around the ear, then it is called a Ramsay-Hunt syndrome. And again, these are some other conditions that have a more kind of a clear viral picture, but they also present with a sudden hearing loss, meaning that's kind of the cornerstone of diagnosing the patients with these other conditions. So some of the non-idiopathic causes, as I kind of mentioned a little bit, are acoustic neuromas or vestibular schwannomas. And for those of you who may not know, these are benign tumors arising from the inner ear nerve. So we have the balance nerve and the hearing nerve that they exit the inner ear and they join together and they enter the brain. So back in the day, they were called acoustic neuromas because they thought these are nerve tumors arising from the hearing nerve. But nowadays, we know that they are indeed, these are a little bit of a technicality, and these terms are still interchangeable, meaning we still sometimes call a tumor an acoustic neuroma, but technically speaking, these are schwannomas. They arise from the lining of the nerve, much like a power cord that you have kind of the copper or the metal in the center and you have the plastic sheath around it. Schwannomas arise from the sheet around the nerve, but they eventually will destroy the nerve as well. And they actually more often arise from the balance nerve rather than the hearing nerve. So technically, it is correct to say vestibular schwannomas, but you can call it both. Then we have the Meniere's disease. That is an inner ear condition. And the other name for it is cochlear hydrops, which Marla mentioned. We tend to kind of differentiate them a little bit. They're in essence the same disease, but if patients have episodic vertigo, we call it the Meniere's disease. If they only have the hearing fluctuation without vertigo, we then call it cochlear hydrops, but the treatment is in essence the same. Sometimes sudden hearing loss could be a sign of stroke, because if the patient also has dizziness, vertigo, or the face goes paralyzed, that's very concerning for stroke. So if that ever happens, even though it could be beginning of a Ramsay-Hunt syndrome, the patient should still go to the ER, get checked, make sure this is not a stroke. They need to get an MRI right in that moment. Malignancies can do that. So sometimes we see patients that, let's say they had a stage 4 breast cancer or prostate cancer, and they come to our office, they say, yeah, I've been under chemo, they have some metastasis or distant tumors that they're watching, and then all of a sudden I lost my hearing. Well, this is very suspicious for a metastasis of the cancer. So again, another important reason to get that MRI done right away, so that we can look and see, okay, is there a new lesion that has popped up in the brain or on the nerves? And then they may need like a lumbar puncture to be tested. And if it's large enough, obviously it needs to be addressed and biopsied and things like that. Noise can do this too. A lot of us may have experienced it in the past. If you go to a loud event, wedding with loud music, maybe a concert, kind of you walk outside, the ears may be ringing, your hearing may be kind of feeling down. So this can happen for some patients, that they may have, let's say, gone to a nightclub, or they were standing next to a speaker and then they were trying to adjust the volume. Somebody outside made a really loud noise, and then they feel like they lost their hearing. So this can happen actually as a result of noise trauma, and also as a result of direct trauma to the skull and to the inner ear. So falling from a ladder, car accidents, playing contact sports, things like that, they can also result in this condition. And also there are medications that are toxic to the inner ear. So a classic example is chemotherapy medications. Anything that is based on cisplatin is high risk. And for some cancers, unfortunately, patients need to receive that. So in those situations, the oncologist usually sends them to us. We get a baseline hearing test and we monitor it, and we advise the patient to come back and see us as soon as you feel like there's been a sudden change in hearing. So vestibular schwannomas, as I mentioned, they are benign tumors of the vestibular nerve or the balance nerve. They can cause hearing loss, tinnitus, and dizziness. And about 10 to 20% of these patients will present with sudden hearing loss to our offices. But of all the patients with sudden hearing loss, the chances of them having a tumor like this is about 2%. So that's why when we see someone, especially because the treatment is time sensitive, we don't wait for an MRI. We still treat them the same way we would treat everyone, but we get an MRI because if this is a tumor, then we're going to be less aggressive with treating them. We would still kind of try to give them the treatment to see if we can bring it back up even a little bit. But if there's a 2-3 centimeter tumor, then we know, okay, doing more probably is not going to change much here. And then the treatment shifts to just monitoring the tumor and addressing that. So diagnosis is with an MRI of the internal auditory canal with and without contrast. So if you ever see another physician or a friend of yours or a family member of yours sees another physician, oftentimes if it's like a general doctor, they might just get a brain MRI without contrast. It is good enough to detect large tumors that distort the brain's anatomy and structure, but it will miss smaller tumors. So for that, we recommend getting an MRI specific of the internal auditory canal with and without contrast, because if there is a 2 millimeter, 3 millimeter, 4 millimeter tumor, you want that contrast to be picked up by the tumor tissue to be detected. And sometimes patients are concerned about contrasts because they're bad for you. You know, some people are allergic to them. Some people have kidney problems. Nowadays, most MRI contrasts are safe for even patients with kidney problems, and they're based on gadolinium, not iodine. So that with CT scans, iodine allergy matters, but not for MRIs as much. So if somebody is diagnosed with this, as I said initially, before they get diagnosed, if they have presented with a sudden hearing loss, we would have treated them the same way. But once the treatment has been, or the diagnosis has been confirmed, then we have the option of observation for smaller tumors or those that don't grow fast, or doing radiation or surgery. So Meniere's disease, as we mentioned, is another common reason for losing hearing suddenly. And what Marla was mentioning, this picture kind of tries to show that, and hopefully it is visible on the screen. But if you look at the top left picture, this is again the inner ear. You have the cochlea or the hearing organ, then you have the vestibule or the balance organ, and then you have three balance canals, and they are each is perpendicular to the other two, and kind of they're in the 3 dimensions, like the XYZ plane. And there are organs within them that they contain fluid, and they travel everywhere inside. And this is what Marla mentioned, that with the endolymphatic sac that is sitting next to the lining of the brain, and it contains the endolymph or the inner ear fluid. And with Meniere's disease, we know how it happens. We still don't know exactly why it happens. We know how it happens is that you get dilation of the fluid chambers inside the inner ear, and it has to do with imbalance of salt, which accumulates inside the inner ear, absorbs water, and those chambers become dilated. People feel pressure, fullness, dizziness, and all those things. And but we still don't know why it happens. Some patients can get it, in their teen years. Some people don't get them until they're in their 50s and 60s. And there have been different theories in terms of what causes this. Some people think it's a genetic predisposition that at some point gets activated. Other people think it has to do with migraine. Some people think it has to do with viruses or with allergies. There is a connection with each and one of these other possibilities, but so far there's not anything we can pinpoint and say, okay, this is exactly how you get Meniere's disease. So it can present with hearing loss. Usually it's fluctuating, but progressive. Over time, it will get worse if it's not treated. Patients can have episodic vertigo, and it is defined as having at least 2 episodes of vertigo lasting 20 minutes or longer. And sometimes people use the terms dizziness and vertigo interchangeably, but we kind of tend to like to differentiate them. When we say vertigo, we mean a spinning sensation or spinning dizziness, versus dizziness in general could be a lot of things. Could be sensation of disequilibrium, could be lightheadedness, could be imbalance, could be sensation of floating. But when we say vertigo, we specifically mean sensation of things spinning around the patients. So the main treatment for Meniere's disease starts with a low salt and caffeine diet, and then we start them on medications, mainly a diuretic. Usually this is hydrochlorothiazide. Some of you may have been on it or may be on it already. It's a good old blood pressure medication. They kind of get rid of salt and fluid from the body, and they also do it from the inner ear. I think like 30, 40 years ago, probably a lot of patients were on the diuretics as treatment for blood pressure. With more kind of a modern way of treating blood pressure, now other medications have priority, but diuretics have stuck around. They're still kind of one of the options, especially for people with, let's say, like heart failure or fluid accumulation inside the body. But for Meniere's disease, this is the first-line treatment for us. It will help kind of reduce the fluid that accumulates inside the inner ear and reduce that dilation of the fluid chambers. Beta-histine is another good medicine that has been introduced. It started kind of in Europe and became standard of practice. Now in the US, we are also prescribing it to the patients, but no pharmaceutical company is still making it. So when we prescribe this to patients, we actually have them buy it from the compound pharmacies, or sometimes it's even cheaper to order from Canada and have it shipped to them. But with the combination of the diuretic and beta-histine as a long-term treatment for Meniere's disease, plus the introduction of the steroids for treatment of acute episodes of sudden drop in hearing, the need for doing surgery on Meniere's patients has dramatically reduced. So 30 years ago, 40 years ago, a lot of patients were getting endolymphatic shunt placement for Meniere's disease, but these days it's very rare. Like over the last year, I've done maybe 2 cases. And like my older associates, like Dr. House, they were probably doing like 1 or 2 a week back then. So with the modern way of treating this, we still offer the surgery, but it's just much less common than before. And so the initial treatment for the acute episodes for both Meniere's disease and also for sudden hearing loss is oral steroids or prednisone. If these don't work, then we introduce steroid injections and gentamicin. And eventually they may need surgeries such as endolymphatic sac surgery, labyrinthectomy, or vestibular nerve section, which is in essence like a craniotomy and opening the brain space. But there are rarely patients that they don't respond to anything that they may need this. We talked about the medications. The common ones that can affect hearing are and some antibiotics such as gentamicin and streptomycin. It is very rare for patients to get these days, except certain like rare resistant infections that patients may end up in the hospital for kind of intestinal infections or urinary infections. They might still give gentamicin, but since people have known about these side effects, the modern doses of these medications are much lower than what would cause a sudden hearing loss. But if somebody went to a hospital, they don't remember what they got, they come to us, they say, yeah, as soon as I got discharged, I lost my hearing. We always try to get the records and see if this was what they were given, because we know this is an ototoxic medication. As I mentioned, chemotherapy medications are very common. And common pain relievers, they can also cause sudden hearing loss, believe it or not. It is rare, but they can do it. So aspirin, Advil, Aleve, they can rarely cause sudden hearing loss. Usually it's not like the common dose that you would take, but if someone is like in severe pain and let's say they have a bad knee pain, they go to the orthopedic surgeon, the regular ones don't work, they try to go up on higher doses, it can actually cause sudden hearing loss. So if somebody ever tries it and they feel like their hearing might be worse, again, they should see someone right away to have that checked out. And certain diuretics that are called loop diuretics or furosemide, they can also cause sudden hearing loss. And this is, again, a very commonly prescribed medication. Usually in lower doses, it is okay. Some patients might still be sensitive to it, but higher doses, it can also damage the inner ear. So in terms of, chances of recovery from sudden hearing loss, if you look at different research studies, they cite anywhere between 32 to 65% chance of spontaneous recovery. Real life, to be honest, this is what I tell patients. If this happens to anyone, I tell them there's a 1/3 chance that you're going to improve and it can come back to normal on its own. Then if we see them right away and we do everything we can, steroids, hyperbaric oxygen therapy, injections, all of that, we still lose another 1/3 of the patients in terms of their hearing not ever coming back to normal. So with all the treatments we do, we try to increase that 1/3 recovery to about 2/3 recovery. But despite our best efforts, as of now, that is kind of the limitation of what we have, that we still cannot bring hearing back in 100% of the patients, but the goal is to at least stopping it from getting worse. And even in patients that their hearing recovers to 100% of baseline, they might still have the tinnitus or tinnitus ongoing even for months after the onset. Because as it comes with tinnitus, even though we hear it as a noise in the ear, it is technically produced by the brain as a result of the hearing loss. So it is a phantom sensation, right? Like we hear it, or whoever's experiencing it hears it, other people in the room, they don't. You may have heard of phantom pain in patients with amputated legs, veterans who've lost a leg. Sometimes they feel like their toes are itching or hurting, even though, the foot is gone. So we think that confuses the brain. The brain is used to getting sensation from the organs, and when it loses it, in some people just cannot process that. It kind of tries to fill in that void or gap by producing that phantom sensation. So that's what we think, at least that's the best theory we have in terms of what causes tinnitus, is that you get that insult, the brain kind of notices it, generates it as a compensation. Now, when you improve the hearing, oftentimes it does go away, but it might sometimes persist because it's a brain phenomenon, not necessarily an ear phenomenon. So the first line treatment is high-dose steroids, even if you cannot see a doctor. If you ever call our office, we always have on-call physicians, and as soon as we hear this, we try to schedule them the first business day. And if you have been a patient at our office before, we would actually send you steroids, because the highest chances of success is to start treatment within 48 hours of the onset. The sooner, the better. I mean, the ideal patient is someone who woke up this morning and I see them 9 a.m. in my clinic, and within 2 hours, we start them on oral steroids. This will give you the highest chances of recovering hearing back to baseline. But still within 2 weeks of onset, it is still considered a good kind of timing. But more often than not, we see patients who come to us and this happened to them a month prior to their office visit, or sometimes even 2 months. It's still up to 2 months we would treat it, but we counsel them that the chances of recovery are not going to be as high as it could have been had we seen them within the first 2 days. The dosage is about 1 milligram per kilogram, and the maximum dose is 60 milligrams per day. So if any of you or any of your friends or family members, they ever experience something like this, they go to the urgent care, they may not feel comfortable prescribing this level of prednisone. This is the highest level of prednisone body can take safely. So a lot of times we see patients who went to the ER or urgent care and they were given just 10 milligrams of prednisone or 20. It is still better than nothing, but it's not the recommended dose. So when we see them, we try to up the dosage to, if they have like a normal body weight, up to 60. If it's a tiny or smaller person, then we would have to adjust the dose for them. Another treatment that has been kind of gaining attention is hyperbaric oxygen treatment. You may have heard of this. It has chronically or historically been used for non-healing wounds, diabetic wounds, cancer wounds, patients with wounds that they just don't heal. The idea is that the better the oxygenation to the tissue is, the better the healing would be. So patients would go and sit in a chamber kind of like this at the bottom of the slide. They give them pressurized oxygen. It's 100% oxygen, and that improves your blood saturation level. So normally, if you check your oxygen level, like if you've ever been to a doctor's office, they put that like little like thingy on your fingers. The numbers are always about like 95, 96, 97. That's kind of the normal oxygenation level. But with this, they increase it to 100% with pressure. And the idea is that the more oxygen you deliver to the tissues, it will heal the wound or the problem better. And it has helped a lot. People thought about, okay, well, this is some sort of an injury to the inner ear. Why don't we try hyperbaric oxygen therapy? And there have been a lot of studies that they show a modest improvement if it's started early enough. Now, one problem with hyperbaric oxygen therapy is that even though it is an indication to prescribe it or recommend it for sudden hearing loss, a lot of insurance companies will not approve it. And it is kind of a cumbersome treatment. You have to go to a center that offers it. Oftentimes there are only a couple around you, so you may need to drive 10, 20 miles. Then you have to be in that chamber for 10 to 20 times and 1 to 2 hour sessions. The cost is about $600 to $700 per session. So if insurance doesn't approve it, you have to pay a lot of cash out of pocket. But it's not going to do magic, but it's just one additional tool in our toolbox to treat the patients. And there are patients that they get approved and we send them, and we think it can augment the initial treatment, but still does not replace the need to prescribe steroids to the patients. And that still remains the main standard treatment. So this has been recommended as an option by our academy, but if somebody doesn't get it, it's not a huge deal. Meaning we've been treating patients with sudden hearing loss, and with the same way we did before with the introduction of hyperbaric oxygen, we still haven't seen a major shift in results. So what I tell patients is that they always ask, okay, what do you think? Should I get it or not? I say, in my opinion, looking at like all the data, there's a 20-30% chance this might help you. And by helping, meaning it might improve your hearing by 20 or 30%. So if you went from 100% normal hearing to 70, 80, getting 20, 30%, I think that's great. Gets you back to normal. You may not need a hearing aid. But if your hearing loss level is already at, let's say, 10% of word understanding, you barely hear noises in that ear, and we bring it up by 20% to about 30%, yes, it is still better than nothing, but you still cannot even put a hearing aid when word understanding is 30%. We would recommend a cochlear implant. So everyone's different, so we always offer it. If somebody wants to go through with it, we try to kind of get approval from insurance, give them a prescription, and appeal if they reject it. But again, this is another thing that's time sensitive, so usually by the time we hear back, you're probably like outside the treatment window. The second most common treatment is actually intratympanic steroid injection. So some people offer this at the same time as starting the oral steroids, but our academy recommends it mainly as a salvage treatment, meaning if the oral steroids didn't work. The idea is that the concentration of steroid inside the inner ear may not reach to the level that we would want it for it to be therapeutic. So by injection, we're in close proximity of the inner ear, so this might actually get absorbed and have a better result. So it kind of may look scary and painful. Obviously, we do it all the time. We try to make it as painless as possible. We usually numb the eardrum with a little medicine. Patients may feel a tiny poke, a little burning sensation that usually takes the pain away. And the actual injection is not that much painful, but the ear will kind of feel full with the medicine filling up the ear. Sometimes can make patients dizzy, but like 99.9% of the patients are able to walk out the office and drive themselves home. So it's not kind of a huge of a deal. But we would fill up the middle ear with the dexamethasone, which is the steroid of choice in this case. And it actually, we don't inject it directly into the inner ear because the inner ear organs are inside like a very thick bone in the skull. And there's a little window here. It's called the round window. And this is the only connection that the inner ear has to the middle ear. And the medicine gets absorbed through that membrane. So we would do anywhere between 2 to 4 injections, usually about 5 to 7 days apart, and we would have the patient come in every time we check their hearing. As soon as the hearing is back to normal, we would stop it, usually after 2-3 injections. If it hasn't changed at all, we also stop, because at that point, there's no point injecting. But if someone's responding, we still inject up to 4 times. It hasn't been proven that the 5th injection is as helpful, but we still offer it to the patient if the patient wants it. So these are all treatments in terms of trying to bring the natural hearing back. But remember, as I mentioned, about 1/3 of the patients, despite everything we do, unfortunately, their hearing does not come back to normal. We then start talking about rehabilitation for sudden hearing loss. So if they have good residual hearing, meaning they have a moderate, maybe mild to moderate hearing loss, or maybe severe and high frequencies, then we look at their word understanding score. And this is the part, again, where the audiologist says the words bike, train, dog, and you repeat those words back. And if you score above 50%, we think that's still good to try hearing aids. So that would be a very good starting option for the patients. And as you guys all know, hearing aids come in different shapes and models. And as long as you get it from an audiologist, you will be in good hands because they know what they're doing. And they will have you try different perhaps models, and hopefully one can help. Then there's another option called bone-anchored hearing devices. Has anyone here seen these or had them, or know what they are? One person. So in essence, there are patients who cannot get a hearing aid, and this would be for them. So imagine somebody who's born with, let's say, like a congenital anomaly of the ear, but the ear cannot never develop, but they still have good inner ear hearing. So how do you help them hear better? This is where the bone-anchored hearing devices come in. And instead of vibrating the eardrum with a normal hearing aid, we would implant an implant into their skull and would vibrate the skull. If you've ever done a hearing test, a part of the hearing test is the audiologist puts the transducer behind your ear, and then you hear through that. So this is, in essence, how a bone-anchored hearing device would work. In this particular situation, if somebody has a sudden, complete loss of hearing in one ear, they essentially go deaf on one side, but they still have one normal hearing ear on the other side. This can be helpful for those patients. So we would do a bone-anchored hearing device on the side that was affected. So if someone's, let's say, they're sitting at a table in a restaurant or in a meeting, someone's sitting next to it, let's say the left ear was affected and they're sitting on the left side and they're talking to the patient, they won't be able to hear from the left ear. They have to constantly turn their right ear to be able to hear the other person. So this will vibrate the skull and send the sounds to the good ear. So if someone's talking to the patient, they won't hear them in the left ear. They will hear them in the right ear, but at least they don't have to constantly turn. Or if, let's say, if it's your right ear and you're the driver, you always have passengers, wife, family, kids, you have to constantly turn, and that can be dangerous. So it can help with driving situation if somebody has it on the right side. Another option is the cochlear implant. So historically, cochlear implants were used for patients with bilateral hearing loss, older patients or patients with like Meniere's disease that they had problems on both sides. Since 2018, they were also FDA approved for single-sided hearing loss or single-sided deafness. And Medicare, unfortunately, still does not cover it for single-sided, but with private insurance plans, we essentially have success getting it approved for about probably like 90% plus of the patients. And this is the only option that can enable a patient with sudden hearing loss to hear again out of the ear. The hearing aid, if it's a little bit of a hearing loss, can help, but if they've lost hearing completely, you can only get a cross hearing aid to send it to the other side, or you can get a bone anchored hearing device to send it to the good side. But this can actually enable patients to hear again in the left ear. And these days, actually, we're doing more of these patients than patients with bilateral hearing loss. But still kind of a little bit of hit and miss, and Medicare, unfortunately, right now does not cover it. But something to certainly keep in mind, even if not for the affected side, as the other side gets worse, then this side can still be affected if the patient meets the Medicare criteria for cochlear implants. All right, so back to that case that I initially presented. So I started her on a course of high-dose prednisone, 60 milligrams for 5 days. I had her come to the office about a week later, and then we checked her hearing. It was a little bit better, not much better. And I ended up injecting her 3 times, intratympanic steroid injections. We got an MRI for her. It was normal. There was no tumors or anything. So remember, this was her hearing test. The bottom line, the blue line, was the ear that was affected, and this is what it looked like after treatment. We essentially brought it back to normal, and she still had some tinnitus, and I saw her last couple weeks ago for something completely different, and she said her tinnitus was gone. It took like a couple of months for it to completely resolve, but this is a prime example of having a successful result, and the patient showing up to our office the day it happened. She woke up. I saw her the same day. We started her treatment right away. As I said, there's still no guarantee it will work like this, but that's kind of when you have the best shot at getting this treated. So kind of a summary and kind of a take-home message is that sudden hearing loss is a true emergency. It is defined as a hearing loss that occurs rapidly within 3 days, most often really overnight or within a couple of hours. And most cases are idiopathic. We don't honestly know what causes them. We think it's a virus, and we treat them as if it is a virus, and that's the best treatment that works. But there could be some other pathologies, which we discussed, and treatment is most effective if started early. But up to 2 weeks, you still have a good shot at getting it treated. And up to 2 months, there's still a long shot. And I would still treat the patients if I see them within the 2 months window. All right, with that, I'm going to conclude. And thank you so much for having me. If there's any questions, I'm happy to ask. Yes, sir.
Hold on a second. Okay, I'm gonna have to run back and forth.
Daniel, can you get the other wireless microphone? Daniel, go get the other microphone, wireless. I'm done. Daniel, sorry.
Was this a mastoid surgery where they remove most of the inside of the ear? Is this the kind of mastoid surgery where they remove most of the mastoid bone and there's a cavity, or is it just a regular tympanoplasty? Are you talking about a mastoid surgery where they remove most of the inside of the ear? So a mastoid surgery is not a surgery aimed at improving hearing. It's mainly aimed at removing cysts or improving infection. However, it does not prevent us from offering patients hearing aids or bone-anchored hearing devices or cochlear implants. It will all come down to what the current state of hearing is. If the hearing is gone completely, then how many years it has been since the onset. And then we look at the anatomy. So there are some options, but it's really specific, meaning specific to the patient, meaning we have to evaluate each patient individually and see if that, for example, an implant is an option for them or not. But the mastoid surgery itself is usually not aimed at improving hearing, but to eradicate a disease.
Something for to be done. In today's life, a typical message for you, how much blood hearing loss do you have?
Can you concisely say what the question was? His microphone is not picking up.
That therapy, how much hearing improvement could be achieved. So if there is an infection or a cyst such as a cholesteatoma, in some patients, if the middle ear structures or the inner ear structures have not been affected, in essence, you could get patient normal hearing again. But if whatever disease they have had, if it has affected the middle ear bones and we need to put a prosthesis, for example, the results are not going to be 100%. We can maybe bring them back to about 70–80% of normal. And if it has affected the inner ear, or they lost sensory neural hearing, then it honestly depends on how much residual hearing they have. Meaning, if it's a lot of hearing loss, then an implant or cochlear implant might be the option. What I'm trying to say is that it really depends on the specific patient. There's not like a one-size-fits-all answer to the mastoid surgery, because it's a wide thing. You can do a simple mastoid where you just drain a little bit of an infection, or you can do a large, what is called canal wall down mastoidectomy for a cyst where we remove most of the mastoid bone. So it really depends on the patient's circumstances. Like medical treatment? Right. So he's asking, if it's an infection, why would it be treated medically rather than surgically? I guess is the question. So medical treatment is still first-line treatment for ear infections, but there are patients that who do not respond to the medical treatment, or they develop an abscess in the ear. That's when we have to then go and do a mastoidectomy. So it's usually not the first-line treatment, but in severe cases, it becomes indicated, meaning then we have to do it. Yes, sir. Oh.
To him. I'll bring it back.
Sure.
I'm sorry, that microphone is not working right, so
Thank you so much for your presentation today, and thank you for your dedication to me and my people who have a hearing loss. And so, fascinating career you've had so far, and all the work that you're putting into understanding these crazy things that go on inside of our head. I was diagnosed with idiopathic sudden hearing loss about 15 years ago, similar to what you explained. Woke up, had an abnormal experience, turned to my wife, Lynn, talk to me, wow, voice sounds different. Again, going through my own internal process, is there water, is there wax? Went to my primary care physician that afternoon, nothing in the external ear, nothing in the middle ear, saying, pretty much, I think it's an inner ear problem, referred to ENT within 2 to 3 days, started on a tapering dose of oral steroids, and it didn't impact me in a recovery way. That case study that you brought up was fascinating. So good for that woman to get almost normal restoration of her hearing. when I experienced this, again, 14, 15 years ago, the operating understanding, it could be infectious, as you suggested, viral. It could be autoimmune. It could be vascular. Again, there was kind of all of the external insults were thought to be potentially causative. One thing that intrigues me about your presentation is it feels or it sounds like the funnel is narrowing, that it might be viral. And it's interesting that, again, the shotgun approach of steroids, which just reduce general inflammation, can help that viral insult. Are there any trials going on if the thought is that it is viral with antiviral medication? So that's one question. The second thing is, so I have a cochlear implant on my right side and then a hearing aid over here. So the hair cells in the right cochlea have been, whatever has happened with the electrode, but I've got normal hair cells in the left side. I think I want to preserve them. And, let's see what happens in the next 10 to 15 years. Can there eventually be some regeneration about those hair cells? So two kinds of questions. Again, what is the thought of specific antiviral therapy if it is virus? And then what is the current thinking about restoration of damaged hair cells?
Antivirals have been tried for sudden hearing loss. They did not work. When it's a Ramsay-Hunt syndrome with the facial paralysis and the rash, then we give the antiviral. But for sudden hearing loss, people have tried it and it hasn't worked. So current research is looking into what is called proteomics of the inner ear. So there are surgeries such as cochlear implant where we actually open the inner ear and we can actually take a small sample of the inner ear fluid. So that is now kind of the next frontier in our line of work. And there's a lot of research being done. So because the inner ear proteins are completely different than all the proteins in other parts of your body. So there's a lot of them that we don't know what they do. So a lot of people are looking into that. They are getting samples. They're categorizing patients based on, okay, this patient has sudden hearing loss. This patient had Meniere's disease. This patient had a tumor. Let's see if we can identify a marker, a biomarker that can, A, help us diagnose you, and B, help us kind of figure out what's going on. So it is a work in progress. We haven't had we don't have it quite like an answer yet, but with the introduction of artificial intelligence, they're kind of like mass feeding these data to AI models, and there are a lot of research ongoing right now. So this would be the next, probably within, I would say, next 10 years. We hope that there will be better answers and better classification of what exactly is going on. And the first part of your first question, sudden hearing loss is probably a symptom of many diseases, right? Even though we always try to categorize everybody in like boxes, probably those that respond to the steroid are those that they have viral infection or autoimmune problem, but some of them are probably like older patients, maybe with vascular disease or blood thinners, they probably just bleed into their ears at some point. And those are patients that sometimes we see that on the MRI. And when we see that, we know steroid, we still offer them the steroid, but we know it's not going to work. So I think right now, we still don't have that ability to further subdivide and say, okay, of all the patients who came to us with sudden hearing loss, let's call this group class A. They have a 90% chance of responding to steroids. This is class B. They're not going to respond. We still don't have that further information and how to classify these patients further. So it's a gunshot approach, as you mentioned. We still treat everybody with steroids. The second part with the hair cell regeneration, there are a lot of research ongoing right now, and nothing has been FDA approved, but it's work in progress. People are also looking into kind of what makes someone more likely to lose hearing as they age. Some genetics involved, and certainly some like environmental factors such as dietary supplements and vitamins. But as of now, there's nothing that we can recommend and tell you, hey, this is what you need to do to preserve your hearing. But what we always tell people is that the best thing you can do is that if you ever have any hearing problem, just come see us or see someone else right away. Avoid loud environments, because if you have one good hearing ear, you are in a place that you're at like exposed to like 95, 100 decibels of loudness, like a really loud event. You really don't want to stay there for too long because otherwise your hearing can get damaged, and repeated exposure will result in worse hearing. That's why a lot of longshoremen or construction workers, they end up with like really worse hearing for their age because of the chronic noise exposure. But certainly a lot of research is ongoing. There's some that we are doing at the House Institute, but as of now, there's nothing I can tell you, all right, this is what you're going to go and do today, and then you'll have benefit in 10 years. But hopefully we'll have that soon. Any other questions?
I don't really have a question, but I have experience. It was at least, I think, a couple of years ago, I had a sudden hearing loss. Amazing, and Gabby checked me out. She said, "I can't help you. We have to see medical." And so I called Kaiser, which I'm a member of. They said it would take me almost 2 weeks to see a doctor. I explained to them the emergency in case they forgot it. And she said, "I don't have anything else to offer." So I went to urgent care, and I got all over the doctor who didn't know what was happening. She gave me a nurse who understood, and they called directly, and they made an appointment within. The result was the doctor put that shot into my ear, and I was amazed that I could not hear going in. We're just fine going out of the office. The shot worked that quickly for me. There was follow-up, but I was amazed with that.
There are patients that they respond very well to the treatment. There are patients who respond very well to the treatment. So, like in your case, it was the shot, but I've also seen patients that, let's say they go see their primary care physician, they work with us a lot, they know what's going on with sudden hearing loss. They already started on steroids before sending them to us for possible injection. By the time we see them, it's back to normal. So, as I said, about 1/3 of the patients, especially if they haven't lost hearing completely, it can come back to normal on its own. And if not with the steroids, we can bring it to about 2/3 of the patients. This kind of adds to, again, to the, what we know, we don't know about this condition, and what we're trying to understand it to figure out exactly who's going to be the responder and who's not going to respond. But yes, there are patients that a single shot or just a couple of days of steroids can help them for sure. Thank you so much.
I just want to say, what happened to Daniel, we were friends at the time, and when he got a 2-week appointment, I said, "No, that's not good enough. You need to get in sooner." And so you have to push it sometimes. You just have to push it. They should all know this, but they didn't. Okay, so we have a little certificate for you. In thanks. So
thank you
for your office.
This
Yes.
is nice. Thank you so much.
Take a picture. And can't thank you enough. Come and share
My
your
pleasure.
expertise. I really appreciate it.
Thanks for having me.
Thank you.
Okay. So that's it for today. I thank you all for coming. Next meeting is going to be about emergency preparedness, and especially since the Palisades fires. And there are special things that you should be aware of because you do have a hearing loss, because you likely have hearing aids. And so we're going to go a little bit above and beyond what the normal preparedness is and talk about how to prepare with your hearing loss. So thank you all for coming. And the next meeting will be the second Monday of the month. I forget what day it is. Do you have a question?
She's deaf. You have. Maybe. I want to remind you that caption call is here. And if you'd like to print out about caption call phones, please visit them. You can have one. We can talk to them about it. Maybe free. Thank you.